Good afternoon and welcome to this webinar on effective patients monitoring strategies. My name is Anastasia Soulier. I am the CNS and Capture the Fracture Partnership Initiative project leader at IOF, and I will be the moderator for today's session. Before introducing our speaker, Professor Thierry Thomas, I would like to inform you that all participants are automatically muted for the duration of the webinar. I would also like to encourage you to ask questions during the session by typing them into the question box of the control panel. I will voice them to Professor Thierry Thomas during the Q&A session we have planned at the end. This being said, I am very pleased to introduce our speaker, Professor Thierry Thomas. Professor Thierry Thomas is a professor of medicine and head of the rheumatology department at the University Hospital of Saint-Étienne in France. He is the president of the French Society of Rheumatology. He sits on the editorial board of Osteoporosis International and is an active member of the International Osteoporosis Foundation, as well as the European Society for Clinical and Economic Aspects of Osteoporosis, Osteoarthritis, and Musculoskeletal Diseases. I will now leave the floor to Professor Thierry Thomas.
Thank you very much, Anastasia, for this kind introduction. Good afternoon to everyone attending this webinar. And with no further words, I will start going through the topic of this webinar, that is the management of patients. And I will divide my presentation in 4 different steps: when, who, what, and how treat and manage the patient. And all these different steps refer to the different best practice framework standards that are included in the questionnaire of the Capture the Fracture program. So for each subtitle, you'll have these different standards. So the first part of the presentation is about identification, evaluation, timing, and vertebral fracture assessment. That are the first 4 BPF standards. So when talking about FLS and patient management, most of the time the story will start at the emergency room, and you have here a picture of the emergency room. In France, it is in what I could call the red room, and it is important to know that it is the first place where you can identify patient, especially if you have numerical files for the patients. Then the second step is usually the operating room. Here with what we could call the blue room, and again it's a step where you can identify patient, usually because you have a good registry of the patient that go to the operating room. And then you'll have the formal organization of the fracture liaison service. So what I just summarized in this couple of pictures is the left part of the slide, the emergency room, then the orthopedic ward, and usually an FLS will focus on patients that are older than 50 with a clinical fracture, and patients that are managed within the hospital through the ER and the orthopedic ward. But of course, the more comprehensive management of patients with osteoporosis should also include patients going through the radiology department with the track of abnormalities on any imaging system that could identify patient with vertebral fracture, even though these imaging were not realized for assessing vertebral fractures. I have in mind, for example, thoracic CT or abdominal CT. That's what we call opportunistic identification of vertebral fractures. Then the different task of the FLS is to identify the patient, call the patient for a visit. It could be inpatient visits, or most of the time, and this is the case in our hospital, outpatient visit, because it's difficult to visit a patient that just had a hip fracture, for example, especially in elderly people. They are shocked by their fracture. There's sometimes confusion because of the painkillers that are used, and we usually, at least in our hands, we usually prefer to see patient afterwards as outpatient visits. And then within the FLS, you'll have the DXA measurement and the visit with a bone specialist, not all the time, but at least for those patients who have a complicated story. I have to say that in France, it is mandatory that it is a physician that visits the patient to initiate a treatment. So it can't be like it is in the UK with just nurses. But the key person in the FLS will be the coordinator, because he will identify the patient coming from the different departments of the hospital. He will make appointment for the DXA measurement, for the bone specialist visit if needed, but he also contact the department that is in charge of fall assessment and fall prevention. Usually it's more in geriatrician department. And the coordinator also make all efforts to coordinate the management of the patient with the GPs for follow-up and treatment renewal over time. This little picture is the area where I work in France. It's a quite large area with different large cities like Lyon, Saint-Etienne, and Grenoble. But the interest of this picture is to show that there are many different sites where patients with osteoporotic fractures are managed to fix the fracture. You have the large blue dots that are big hospitals, as well as the green ones that are usually university hospitals or large institutions. And in these institutions, there is definitely enough room and enough human resources to set up an FLS and manage appropriately the patient. But you see also in this cartoon that there are a lot of little purple dots that are small hospitals that also manage this patient. And in these smaller hospitals, most of the time you can't organize the management of the patients through an FLS. So you have to go to a more appropriate and personalized organization. Currently, we have two different systems beside FLSs in France. The first one is a program that is called Prado, and the Prado organization is based on an employee of the social security system that more or less does the job of the coordinator of an FLS, but it comes from outside, and it tried to make in connection the different resources that are needed to manage the patient. Of course, the hospital and the surgical team in the orthopedic ward, but also the GP and some offices where you can find DEXA and if needed, a physiotherapist and so on. So it at least this social security employee tries to better organize the journey of the patient, because in the specific situation of a patient with an osteoporotic fractures, you have many different healthcare providers that have to be involved in the management of the patient. And the third organization I wanted briefly to share with you is a new organization that is proposed in a new law we have in France, dedicated for healthcare management. And this alternative kind of FLS is more like an open structure network that is formally set up between the hospitals, large one and smaller ones, depending on the area, and a network of GP, but not only GPs, but also physiotherapists, dentists, pharmacists, and so on. And again, there is a coordinator in this system, and that I think that is really a mandatory human resource to have a good management of an osteoporotic patient, is to have this coordinator. But in this specific alternative FLS, the coordinator is within the GP network instead of being within the FLS embedded in a large hospital. So there are many different kind of organizations that are there to fit to the specificity of the different areas we have in France, and I'm sure you have also in your countries. That was for the first part. So the second part is who we're going to treat through the FLS, and it refers to the BPF standards 5 to 7, going from assessment guidelines to evaluation of secondary causes and falls prevention. To decide if a patient needs a treatment, we have to evaluate his fracture risk, because the main objective of a treatment is still today to reduce the risk of a future fracture. And I would like briefly to go through the 4 very important key factors risk that will help us to decide if the patient needs a fracture or not. The first item is age. The second one is evaluating risk of falls, and it is very important, at least for patients that are higher than 70. And then the history of the patient with previous fracture and the recency of the previous fracture. And the fourth one is BMD assessment. Age is a very simple risk to assess, of course, but it is important to keep that in mind, especially depending of the location of the fracture and depending of the gender of the patient. I took the example of hip fractures on the left-hand side of the slide and wrist on the right-hand side of the slide. And that is the pyramid of the patients that were hospitalized in France for fractures, and that was a couple of years ago. For hip, you can see that most of hip fractures occur after the age of 70 to 75, and is still a largely female problem, with 3/4 of the fractures that occurs in women. For wrist, the situation is really different. For males, you see that the rate of fractures with different ages is very similar up to the age of 70, and you can assume that most of the wrist fractures in male are traumatic fractures. But in female, you see that right after the age of 50 to 55, you have a tremendous increase in the risk, in the occurrence of wrist fractures, suggesting that a large part of wrist fractures in women are definitely osteoporotic fractures. Then the second key fracture risk is, of course, the risk of falls, and that has to be briefly assessed by the healthcare provider that will visit the patient in the FLS. And if there is history of falls in the last 3 to 6 months prior to the fall that led to the first fractures, or if you have the ability to perform very simple tests like the get and go test or the sternal push test, then you should refer the patient to a falls prevention service, because that's definitely where you will be able to manage the patient with the objective of reducing the risk of future falls. And this is a real opportunity to reduce the risk of fracture when you combine the management of fall risk and the treatment of osteoporosis. If you have no fall prevention service, you can still work with a physiotherapist. It's probably not as good as the dedicated organizations, but it's still worth to make any effort to reduce the risk of fall, especially for non-vertebral fractures. What is important, at least in our hands, is to do this brief evaluation of the risk of falls if your fall prevention service is not big enough to manage all the patients that you will visit in your FLS. And in most situations, it is the time. It is very time consuming to evaluate a patient appropriately to reduce his future risk of fall. So if you can do some kind of triage before referring the patient to this specific service, it is certainly a good way to go. Then, as I said, after age, after the history of falls, then you have the history of previous fracture. And it is certainly very important to have in mind that if the first fracture or the fracture that brings the patient to your FLS, you have to evaluate his bone status and his risk of a future fracture in a very short time frame. And we consider in the Capture the Fracture program that a good way to go would be to do that in a 8-week period between the fracture occurrence and the initiation of the treatment. Why that? First of all, because patient that already has a fracture is at high risk of future fractures. And second, because if the fracture is recent, his risk of having a second fracture will be even higher in the first 2 years that will follow the occurrence of this first fracture, and that is what is figures on this chart that is from a publication from an Icelandic cohort. You have this line with dots on the bottom of the chart, and that shows the risk of a woman that is age 75 with no specific risk of fractures. And above that, you have a full line that represents the risk of a second major osteoporotic fracture for someone that already had one. And you see again that the difference between the two lines is really tremendous in these first 2 years. Years are on the x-axis of the graph, and then the risk will comes down to roughly twofold increase, and this difference will remain over time. But we really need to be efficient in this short period of time following the first event. And you also have to keep in mind that a fracture event is the witness of the bone fragility, of course, but to the overall fragility of a patient. And there is a good link between the two. And I show you here a very interesting study that was performed in the GIBO courts in Australia. And what they did in this specific study, they split their population in two groups depending on the year they were born, before 1930 and after 1930. And regardless of the age of the patients and the confounding factors, they looked at the mortality rate after fractures. And what is very interesting is regardless of the group and the age of the fracture and so on, the risk of the rate of mortality after fracture, and again, all fractures, hip fractures, non-hip, non-vert fractures, is very similar for these two groups. So what we can conclude from that is if a patient gets a fracture, is in a situation of overall fragility, including bone fragility. Then the fourth item that is important for us, at least in France, to evaluate is bone mineral density, because we consider that it is important to know when you decide to initiate a treatment to evaluate the level of bone mineral density before deciding which kind of treatment you're going to use and for how long you will have to treat the patient. And what is also important is that if you assess bone mineral density by DEXA, you can also evaluate the occurrence of vertebral fractures in the past. You can calculate if the patient has prevalent fractures, and with the VA technique. So with the same measurement, you can have the bone mineral density assessment, and you can assess the number of prevalent vertebral fractures. And these two factors are important for you to evaluate the risk of further fractures, but it can also help you in the decision of which kind of treatment you're going to use. And for example, in France, you can only use teriparatide if the patient had already two vertebral fractures. So it is for us an important tool to go through because it is important for the evaluation of the risk, but it is also important to the treatment decision. I will skip that one. Then, after you have assessed all these different fracture risk factors, and I only went through the four key factors. Then you have to make your decision whether the patient should be treated or not. And in France, we decided in our last guidelines published in 2018 that to make it simple, you can make your decision based on the clinical situation of the patient and the level of BMD. So we defined three different situations. The first one is a patient with a severe osteoporotic fracture, namely femur, humerus, vertebrae, or pelvis. The second situation is a patient with a non-severe osteoporotic fractures, so all the other fractures, rib, wrist, ankle, and so on. And the third situation is a patient with no fracture, but with risk factors of osteoporosis or falls that led you to measure the bone mineral density of the patient. And then you can plot these three different clinical situations with the level of BMD based on the T-score, and you pick the lowest value. And then you have four different situations: above -1, below -1, below -2, below -3. If the situation is a patient with a severe osteoporotic fracture, again, femur, humerus vertebra, or pelvis, then this patient has definitely osteoporosis, is a patient at very high risk of having a new fracture. You have to treat the patient when the T-score is below -1. If it is above -1, it's probably good to have a bone specialist opinion, because it's a very unusual situation, probably less than 1% of the cases. If it is a non-severe fracture, like wrist, for example, then the threshold of the BMD that will lead to treatment is more stringent, and we recommend to treat patients with a T-score below -2. If the T-score is above -1, it is definitely a traumatic fracture, especially at the wrist or the ankle. And if it is in between -1 and -2, it may be good to have a bone specialist opinion to be sure that the patient needs or not a treatment based on other criteria, like bone markers, for example. And if a patient has no previous fracture, but as risk factor for osteoporosis, and indeed has a low BMD, then if the BMD is below -3, the patient needs to be treated. Above -1, no need for treatment, and between -2 and -3, probably it's good to have a bone specialist opinion. So it's the -1, -2, -3 guidelines, so very easy to remember, and 3 different clinical situations to deal with. Of course, there are different options, and I just figure here the FRAX tool that is used in many different countries, especially close to us in the UK. But you can see on the figures and at the bottom right of the slides that comparing the number of hits in UK to the number of hits in France, there is a huge difference in the use of FRAX in these 2 different countries. So then, what to give to the patient? The first very important point is that the patient has to be proactive in his treatment, rather than just reactive to what you give to the patient. Your role will be to prescribe medications, of course, but your role will be to embark the patient in all he can do by himself to improve his bone status. And you'll have to evaluate his diet. You'll have to evaluate his intake of calcium and vitamin D, and you will have to correct his diet and maybe use supplementation for calcium and vitamin D. Of course, you'll have to prevent falls, either yourself or the physiotherapist or the fall prevention department you'll refer the patient to. And you have also to stimulate the patient to engage in a regular weight-bearing and balance exercise that is good for the bone status and good also for reducing falls. And you'll have also to limit the alcohol consumption and the use of tobacco. That is deleterious for bone. So when you will initiate the treatment, and I do believe it is important that it is during the EFLS visits that the initiation has to be done. You have to sanctuarize this step. everything that is on this slide is important for a good adherence to the treatment. Then you have the choice of the treatment. In the past, in the last 20th century, everything was based on efficacy, and it was easy to convince the patient that a treatment had demonstrated its effectiveness. But you all know that now safety is very important for the patient, and it's definitely a balance between efficacy and safety that is important to show to the patient, because when you'll arrive to the step where you will present the treatment to the patient, he will tell you that he already went to websites and he is fully aware that there are risks with anti-osteoporotic drugs. He don't understand really what it means, but he is worried with the drug. So you'll have to keep that in mind when you explain the appropriateness of the treatment. Then you have the difficult choice of the treatment. In most countries, and it is the case in France, the first line treatment is bisphosphonate. They are the cheapest drugs, and they have well demonstrated their effectiveness. In our guidelines, we put upfront zoledronic acid in patients with hip fracture because we have one specific clinical trial that indeed demonstrated the effectiveness of zoledronic acid in this specific population. We also proposed some clinical vignettes in our recommendations, but they are definitely linked to the reimbursement conditions of the different drugs in our country, and I know that these reimbursement conditions change from country to country. But for example, if a patient has two prevalent vertebral fractures, for example, if you assess that using VFA, then you can use teriparatide as a bone-forming agent. We still don't have romosozumab in France. But if you can use a bone-forming agent, that's probably the way to go, keeping in mind that you will have to do that in a sequential treatment, and you will have to use an anti-resorptive agent after the first 18 months of teriparatide. If it is a young woman below the age of 65 with a low risk of non-vertebral fracture, especially if it is not a patient with 4 or previous non-vert fractures, you can definitely use raloxifene. In our country, raloxifene is reimbursed up to the age of 70. If it is even a younger woman below the age of 60 years with a climateric syndrome and osteoporosis, then HRT is still a good option. If you start a treatment in a patient with a very low BMD below -3, then you have to consider if you can use sequential treatments that will help you to bring back the BMD above what you could define as a treatment target that is above -2 in our guideline. And when I speak about sequential treatment, it could be either teriparatide followed by an anti-resorptive drug, or denosumab. You know that denosumab will increase the BMD of the patient as long as you treat the patient. And then if you decide to stop the treatment because you're at the target, then you'll have to switch to a bisphosphonate to stabilize the bone gain you had under denosumab. Then coming back to the FLS team, you have many different healthcare providers in FLS, and all of them are needed for an appropriate management and for a good journey of a patient with an osteoporotic fracture. But what is important again to have in mind is what you're able to do in your own FLS. If you have small resources, then you have to start small. You won't be able to manage all the patient, so start with the patient that are easy for you to identify first, and then manage second. If it is patient with hip fractures, and usually they are the most easiest patient to identify in hospitals, then start just with patient with hip fractures. If you are in a hospital where the patient with wrist fractures are the first target, then you should start with that. Of course, if you have from scratch enough resources to go larger, then you can manage all patients above the age of 50, but it's probably more difficult to start with all different kind of patient at first. It's probably better to set up your organization, and also in this you also have to keep in mind who will initiate the treatment and then who will follow the patient. And keep in mind that in a lot of situations it won't be the FLS itself that will initiate the treatment, but it will be probably the primary care or secondary care. Then you'll have to follow the patient, and again, it's probably good that the FLS is at least in part involved in the follow-up of the patient to be sure that adherence to the treatment is okay, tolerance of the treatment is good, and perform some monitoring of the patient using bone turnover marking at the beginning, and then BMD monitoring on the follow-up. And I will touch again on this approach that is very interesting in our mind, is this treat to targets strategy. If you start with a patient with a low BMD, then one of your goals is to improve the BMD and is to push the BMD back to a normal level, or at least in range between -1.5 and -2, because we have very good data now showing that the higher the BMD you get with your treatment, the lower the risk of future fracture the patient has. At least what you expect is no bone loss, but you certainly can do better, especially for patients who start treatment with a low femoral BMD. And then it will help you to decide whether you can stop or not the treatment. And in our guidelines, we consider that you can only stop the treatment not only if you have a first duration of treatment of 3 to 5 years, but also if you have no new fracture under treatment, no new risk factors, no significant decrease in BMD, and again, a femoral T-score above -2. Fall prevention. Who will perform fall prevention? Is it your FLS? Is it a physiotherapist close to where the patient lives, or a specific fall prevention service? That has to be decided and organized for the patient. So if I try to summarize these presentation, what I could say is, first, for a good and effective patient monitoring strategy, you have to establish a coordinated pathway for all your osteoporotic patient. You have to assess the level of and the imminence of future fracture risk. You have to regularly, you yourself or the GP, you have to evaluate the needs, the benefits, and the risk of therapies, and it's probably good to have appropriate coordination. And to do that, you have to communicate. A large part of good FLS is a good communication between the orthopedic surgeon, your FLS, the GPs, the physiotherapists, and so on. And within this communication, you have to clearly define the respective roles of the different healthcare providers. And you also have to make the patient aware of who is doing what. This is an FLS. An FLS is dedicated for patients with osteoporotic fractures, but you also have to keep in mind that is only a part of the osteoporosis scope. And just to finish, I show you the different tools you can find on the Capture the Fracture website, and you have the website at the bottom of the slides. And with that, I will definitely thank the IOF to organize this webinar, and the different sponsors of the program. And I'm ready to listen to your question. Thank you for your attention.
Professor Thierry Thomas, thank you for this excellent presentation. I will now read the questions received from the participants. So the first question is, do you use denosumab?
Yes, I use denosumab in a lot of situations. Actually, whenever I can use it, I do so. And the reason for that is mainly because I think denosumab, like all different sequential treatments, is a good treatment to match with the treat to target strategy. If you have a patient that has a baseline BMD T-score that is around -3, when you decide to initiate an anti-osteoporotic treatment, you will have hard time to bring his BMD back above -2 or around -1.5 with just a bisphosphonate, even an IV bisphosphonate. So it is definitely a long-term denosumab treatment that will help you to do that. And we have, again, good scientific data showing that for the future risk of fractures, it is better to have a good BMD at the end of the treatment.
Thank you, Professor Thierry Thomas. The next question is, what medication for osteoporosis do you use if vitamin D level is low?
Before starting anti-osteoporotic treatment like DMAP, bisphosphonate, and so on, of course, it's mandatory to bring back the vitamin D level to an appropriate level. And in our country, the guidelines says above 30 nanogram per mil, but in other countries, it's sometimes 20. to bring back the vitamin D level to a normal level, it's probably good to do that fast because you want to start the treatment fast as well. So you can use either 50,000 units or 100,000 units of vitamin D. If you use 50,000 units, you can probably give 50,000 units each week. If you start with a very low level and you give the vitamin D for at least 1 month at that dosage. If you start with a vitamin D that is between 15 and 20, you can probably do that on a shorter period of time. You have to check if you were able to bring the vitamin D level back to what is expected. And then it is the second phase of vitamin D supplementation. And the second phase, you can use either vitamin D once a month, for example, with 50,000 units each month. If it's a patient with a high BMI, probably good to go up to 100,000 units per month. But you also have to keep in mind that what is the best is to give that on a daily basis. But the problem of the daily basis is the adherence to the treatment. So you have to compromise between the what is the most efficient way on a daily basis with like 1,000 units per day, or the adherence to the treatment, and sometimes we have better adherence with the monthly basis. So you can choose between the two.
Okay, thank you very much. The next question is the following. Why in the French guidelines is the threshold for starting treatment for non-fracture group patients is T-score -3, which is different from the WHO and other countries' guidelines?
The different thresholds are based on the clinical situations, and so in France, if you have no previous fractures, actually anti-osteoporotic treatments are not reimbursed if the T-score is above -3. So it's part of the answer to the question. So it's partly related to the reimbursement conditions, but it's also partly because the risk of having a fracture is really important if the T-score is below -3 when you have no other fracture risk. That is the reason why there is this guideline. If you have a T-score that is below -2.5 and additional fracture risk, and it is in the text of guidelines, then you can also decide that the patient needs a treatment. But it's a compromise between what the science says to us and what the authorities authorize with reimbursement.
Thank you very much. The next question is the following. I would like to ask you about the management of pre-menopausal osteoporosis.
Well, that is a different situation, of course. What is very different if you have a patient that is premenopausal women with osteoporosis, what is really different is the diagnosis part of your visit, because you'll have to be sure that it is a primary osteoporosis, and that this osteoporosis is not a secondary form of osteoporosis. So it means that in your search for other diseases associated with osteoporosis, you find nothing. So for example, your biological assessment will be larger. You'll have to search, for example, for mastocytosis, celiac disease. You will also have to be sure that there is no phosphorus diabetes. You really need to be sure of that. Then it's a patient-to-patient decision whether you should treat the patient or not. And in premenopausal women, in most circumstances, we only treat patients that already have one fracture. It's difficult to make a decision just because the BMD is low, or only if the BMD is very low. Of course, I put apart the situation of corticosteroid-induced osteoporosis. That is a very specific situation. But even in this situation, in our guidelines, it's a patient-to-patient decision. But because in these young patients, you have actually very few fractures, even though BMD can be low.
Okay, thank you very much. I think we just have time for 2 more questions.
Okay.
So the next one is the following. Is oral bisphosphonate a reasonable option post denosumab if they cannot tolerate full bisphosphonate? Type 4 bisphosphonate.
Yeah. You know that the data we have for using bisphosphonate after denosumab, if you decide to stop the denosumab, that is the first part of the answer, you may decide to continue the bisphosphonate, the denosumab. But if you decide to stop the denosumab, the data we have are not going in the same direction for all data. Some are very reassuring, some are not, saying that an oral bisphosphonate may be not sufficient to prevent the bone loss after you stop the denosumab. And what we have as information from clinical data coming from different trials that were recently published is that if the patient is under DMAB for a long time, the risk of having severe bone loss at the end of DMAB is important. And in these circumstances, oral bisphosphonate may be not enough. If the duration of DMAB is short, with just a couple of years, then it may be okay. But you have to monitor that. And you don't have to wait for a reevaluation of BMD. You have to monitor the patient with bone turnover markers. And if after a couple of months, that's 3 months, if after 3 months your oral bisphosphonate is not sufficient to prevent an increase in bone remodeling, then you have to change your mind. And if you can't give an IV bisphosphonate, then you probably have a better option to go back to DMAB.
Thank you very much, Professor Thierry Thomas. We have now come to the end of our webinar. So do you want to say a few words before we close the webinar?
Oh, it was a real pleasure to do this webinar with the help of IOF. I thank, of course, Anastasia to help me to do that. Also thank Jake from the IOF organization that helped me in preparing this webinar. And I do thank you for your attention and your questions for this Q&A session. And I wish you a very, very nice Christmas break.
Thank you very much, Professor Thierry Thomas. On behalf of IOF, I would like to thank you all for your participation today, and I hope that you enjoyed this session. We'll publish the recording of this webinar on the IOF website, and you'll also receive the link by email tomorrow. You will also be prompted to complete a brief survey immediately after this webinar, and we would really appreciate your input and comments as we continuously try to deliver webinars that meet your needs. If you have any questions or comments, please don't hesitate to contact us by email at the following email address, webinar@iofburnhealth.org. I would like to again thank Professor Thierry Thomas for his outstanding presentation and to thank you all again for your participation and attention. I am sorry we did not have time to answer all your questions, but we thank you for your great input during this session. On that note, I wish you all a very pleasant afternoon and evening ahead. Goodbye for now.
Goodbye.